Okay, thank you, Dr. Lim, for being on our show today. I really appreciate it.
No, thanks, Rebecca, for having me. I have followed Children's Airway Health Foundation, the website and the blogs and all the resources that you guys have created. So I'm really excited to be involved with this to support what you guys are doing.
Well, thank you. I appreciate that. And just so everybody knows, at the end of the show, in our show notes, I'll make sure to put links about everything we talk about. Mm-hmm. And when I reference your book, just so people can see it, this is the book I will be referencing throughout our conversation. And especially parents, if you haven't read it, I cannot recommend it enough. Please read it. It's amazing. You'll get your footing. There's so much information in there, and it's a great book. So that being said, I thought we could start off a little bit talking about, on your website, you've got your vision and mission statement. And I want to talk about that because to me, that sets the groundwork for everything we're going to talk about throughout the course of this podcast. And on there, you say your vision is to grow a global community of airway and sleep health advocates to help more people breathe, sleep, and thrive to their full potential. Mm-hmm. So how do we do this? And why now? Why is suddenly this, bubbled up to be such a big conversation topic?
Yeah, I mean, in the past, traditional healthcare has been really focused on treating symptoms such as depression, ADHD, heart problems, and without really looking at the root causes of those issues. And many times when we have poor breathing and poor sleep, that will actually play out with these symptoms and increased risk of these problems. So rather than medicating people and people surgeries and all the research focusing on these medications, I want people to go back and look at how are people breathing and sleeping. This is where we spend a lot of our time during the day. And if we don't breathe well, we're not going to live well. So I think it's really important to get this word out. We can most affect people when we treat people in the earliest years of life. So we can't really afford to wait longer and longer. There's a lot of new research that suggests that we need to work collaboratively to ensure people breathe well and grow healthy airways. And it's time to get this information out so that we don't miss that boat for many of these children.
Right. And I actually have two different questions kind of to follow up with this, because one thing you just touched on it, and I've heard you speak about this before in other podcasts and other presentations, where you talk about the stage of breathing dysfunctions and that the earliest origins are gestational and infancy. So, how is it possible for these dysfunctions to appear, during pregnancy? And then, if we identify them, how early can we treat them?
Yeah, sure. So I think it's really important for people to recognize when we have problems like breathing, like snoring and sleep apnea, they do have developmental origins. They're not something that suddenly occurs when you put on weight or when you grow older. They have their roots in how well is the jaw growing, the jaw structures being the floor of the nose, the house for the tongue, the support for our upper airway or throat. And so these jaws, they grow the most in the first 6 years of life. Even the first year is the most rapid period of development. And what stimulates those jaws to develop is how well we use our muscles during sucking, swallowing, and breathing. Now, sucking and swallowing begins in utero. There's been like fetal echography studies that show that from 18 weeks, there's that constant sucking and swallowing pattern going. And so there has been some work presented by Dr. Christian Gimeno, which found that these high palates and retrognathic or receded jaws can be found very early, even before birth. And they're a reflection of dysfunctional sucking and swallowing in utero. Yeah. Okay. And so because the sucking and swallowing peaks around the third trimester as well, we also have to be aware of high risk groups like premature births, because when babies are born premature, they miss a significant chunk of their sucking and swallowing training, and they don't build good muscle tone. And so these children as well, they're going to be at risk of high arch palate and problems with their jaw development and their muscle tone as well.
So if we see it in utero, at this point, just, so I understand, there's really nothing we can do about it at that point. But if we see it, then we can be prepared to do something. How quickly once the baby is born?
Well, I think the first function, the most important modifiable influence on jaw development is going to be breastfeeding in that first year of life. So we want to promote the mechanical benefits of breastfeeding to allow parents to make that fully informed decision. Because when we have breastfeeding, it does require, for optimal transfer of milk, good tongue function and good suction. So it's really actually the tongue suctioning to the roof of the mouth. And as it drops, it creates a vacuum, and that's how milk is effectively transferred. And that promotes good swallowing. So even in utero, it's that action that actually stimulates proper palate development. So I'm involved with a lot of tongue touchment from infancy, and we can really see these high arch palates and the correlation with the degree that that tongue can suction. And yes, we can identify these issues. We can't really change the palate in a big way when it's already very high. But what we can do is we can promote breastfeeding and proper suction of that tongue. And that can sometimes mean tongue tie release, or working with a good lactation consultant who can really optimize the latch and help ensure that we're getting the deepest possible latch and allowing that tongue to function as best as possible. And we also want...
And that stretches, that will help stretch and move the mouth, expand it naturally?
Yeah. The more and more toned that tongue is and working well, the more our muscles are working, that will actually provide the proper stimulus for the jaws to grow well. However, sometimes that palate is so high that no matter what we do, it's really hard for that tongue to reach the roof of the palate and to stimulate more normal development. So we can identify that these are the children that are going to have more problems. And we want to minimize dummy use or pacifier use, which actually promotes low tongue posture, and incorrect swallowing, which sort of distorts the palate further. And I'm a big advocate for things like osteopathic treatment to kind of help to release any cranial strains or just allow the bones to move more freely and develop more normally. And at the age of 6 years to be able to then introduce good chewing, harder diets rather than overdoing the purees, baby-led weaning. I think that's a really good approach to look into. Just everything that we can do to get the muscles working well, because we can't really do palate expansion until children have developed their set of 20 baby teeth that we require to support the expander.
Well, that kind of answers one of my questions. When can we start it? So you obviously we're much later than infancy at that point.
Yes. Yeah. So for palate expansion, I have colleagues that are doing it from the age of 2 years. My comfort zone is age 3. So if a child is pretty easy to engage with, or they can sit in the chair for a full set of photos, then often they could be a very good candidate, particularly if they're not breathing well, sleeping well, behavioral concerns, difficult to manage, emotional regulation. They're the children that I might want to look at intervening sooner. There really is no need to wait until the permanent teeth come through, because the brain development, 90% is done by the first 3 years of life. The child's brain is 90% of the adult size by age 3, or something like that. I may not be quite accurate there, but a lot of development goes on in those early years of life. So we want to make sure that they are sleeping and breathing well, and palate expansion being a very good intervention to address that risk factor.
And then with palate expansion, that device is put in and it's relatively permanent, right? It's not something that the child pops out in or out daily, correct?
There's actually quite a few different appliances and different ways that you can expand the palate.
Okay.
And the way that palate expansion works, to get true bony expansion, it works because in the middle of the palate, there's a midline suture and it's not completely fused. It starts fusing around the age of 9. And so if we gently separate the two halves of the palate, we can actually stimulate bone. It's also called distraction osteogenesis. So there are multiple types of appliances, and anything that has the key that you turn can actually open up that suture and stimulate the bone. So there are fixed appliances and there are removable appliances. And so any of those appliances can work in a very young child just because their suture is so open to movement. And so I tend to use removable appliances. I'm really comfortable with the use of the BioBlock appliance, but there are multiple ways to do it. So obviously with a removable, it does require compliance. Children, I get them to wear it full time, to eat, to sleep, to go to kindy or school. And you do require a compliant child, but more importantly, a compliant, like a parent that's really on board to can help supervise. So it may not be for everybody. There are multiple ways of doing it, but it is really the ones with a screw that we're looking for, because there are things like ALF appliances and Invisalign that don't really produce that true skeletal bone expansion right at the midline, which is the floor of the nose. Still can be good for making more tongue space, but not as proven or well studied to improve sleep and breathing quickly.
Gotcha. And what's the difference between a mandibular advancement device and palate expansion or a palate expander?
So mandibular advancement devices are typically used for non-growing people like adults who with snoring and obstructive sleep apnea. And what they do, they're worn during sleep to actually advance the lower jaw forward. And the aim of those appliances is to help improve breathing or open up the airway. By advancing the lower jaw forward, we're bringing the tongue forward, because the tongue is often a risk factor for collapsed breathing during sleep. And when we bring our lower jaw forward and our tongue comes forward, it stretches open the muscles of the throat. So it helps to keep the airway more open during sleep. And so they're quite effective for certain individuals that have receded jaws, and they do help people with their sleep quality. But it really is a Band-Aid solution for a problem with jaw development. And so I do think that we can do better for our patients if we actually get in early and help their jaws grow better and address those oral dysfunctions that lead to poor jaw development.
Right, because if we can do this early or earlier,
Yes.
right,
Yeah.
then we're preventing these adults that are having just a plethora of issues. It's amazing how much is related.
Yeah, I think I first got into snoring and sleep apnea because of my husband snoring and really looking into these dental sleep appliances. And as much as they can help people's quality of life, it really is a Band-Aid solution. And often people ultimately, after a long period of time, they may have different problems with it, like their jaw problems, or they break and lose it, and then they can't really live without it. It's kind of like a crutch. So I also think that for adults with snoring and sleep apnea, yes, it can be very despairing. It can really affect their quality of life. And that's one of the reasons why I think we need early intervention. But for adults, I think beyond those type of Band-Aid solutions as well, we really need to look at how can we help improve their breathing daytime and nighttime as well, so that they can actually get better and they don't have to rely on these nighttime crutches. And when we're looking at what are the best solutions for adults, or what's really going to help improve their quality of life without them having to rely on things, we're really looking at advanced jaw surgeries like palate expansion for adults, which is a lot more difficult than doing it in children, or double jaw advancement surgeries and that sort of thing as well. So, it's really complex, and sometimes it's really hard to find providers that really can understand and integrate these treatments. When do we do palate expansion? When do we do double jaw advancement surgery? And so I really do think at the end of the day, we need to intervene early. Earlier
is definitely the way. And when you mentioned that it is kind of a Band-Aid, CPAP is something that we hear a lot about, especially on our program, people talk about that. And the reason I'm bringing this up is because you mentioned a Band-Aid, and I've always wondered if the point at night is for it to push all this extra air in, what happens to these people during the day? So in theory, if that's helping you at night, you're still walking around during the day without any help or support. You're not snoring, but that issue does still exist, correct?
It is, because the snoring is really a symptom of poor airway development. And it's the problem really is a constricted airway, but it plays out during sleep because during time we can keep our mouth open, all our reflexes are intact, but during sleep, when we're lying on our backs, the tongue is more likely to flop. When all our muscles are more relaxed, our reflexes that keep our upper airway open, they're not as intact. This is when it plays out. So it is actually more of a day problem, a airway problem that plays out during sleep. So yeah, CPAP, again, really it's a Band-Aid solution. There are so many people that can't tolerate it. And even when they do, the long-term compliance is not really that great. And so again, nowadays people want to be healthier. They want to actually work out what is a solution. How can I actually get healthier rather than rely on these problems? And it really does come down to jaw surgery. So a lot more adults are becoming interested in how can we do these double jaw surgeries or this palate expansion.
Right, to get to the root and fix it so that they've got this long-term solution.
That's right. Yeah, but along the way, we've missed all those warning signs, and people have suffered for decades without having, a clear mind or good attention, concentration, and all the other symptoms that go with it.
Yeah. And you talk, and we've talked about this on our programs before, but in your book, you talk a great deal about tongue ties in children. And I found that quite interesting, because even as much as we've talked about it, the way you explain it and the visuals that go along with it, it really helps to clarify things. But just for some of our parents who maybe haven't read this yet, so how can we accurately identify a tongue tie? Because I think we've all done this. You go in the mirror and you lift up your tongue and you see that little thing hanging down and you think, oh, I have a tongue tie. So how do you actually identify a tongue tie? And as parents, what are we looking for specifically?
Yeah, it is quite a complicated question to answer, because a lot of us as health professionals, even dentists, we consider oral physicians or physicians of the mouth. We are not taught anything about tongue tie in dental school. So it's really hard for us to be able to identify anything beyond the very obvious tongue tie that goes all the way to the tip of the tongue. So they're pretty readily identifiable, often can be picked up by pediatricians in hospital. But the ones that are more tricky and more grey and less easy to diagnose are called posterior tongue ties. And these ones are more hidden, as in they don't extend necessarily all the way to the tip of the tongue. They may be a little bit further back, but what they can do is they can prevent that normal suction for efficient transfer of milk, and that normal suction for good tongue posture to actually develop the palate properly, and for that tongue to be well toned to help keep our airway open during sleep. So how do we identify them? Well, we really do need to work with people that are really well trained, and usually these are people that have actually gone and done further study beyond traditional medical and dental training. So working with people that are really involved with tongue tie management on a daily basis. And really, we do need to lie babies down and manually lift up the tongue to actually have a look and to really feel the degree of restriction. And we need to be able to take into account what is the feeding like and what are the symptoms experienced by parents. Sometimes if there is pain or there's problems with weight gain or fussy feeding, we really need to not rule out posterior tongue tie and have that properly investigated. Because there's now a lot of research to support that posterior tongue tie, or that those more hidden tongue ties are implicated in reflux-like symptoms or aerophagia. And babies are getting put on medications and all sorts of things like thickeners and different things, but really we're not addressing the root issue, which is poor swallowing and sucking and the excessive intake of air, which leads to all those issues. And sometimes tongue tie release can be a helpful intervention to manage that. So I think the most important thing for parents is to recognize that it's not always a straightforward, easy diagnosis that we are trained as professionals to look for. If there are problems, you want to work with really well-trained international board certified lactation consultants and your other professionals that really have a special interest in this area. that will
And
take into account your symptoms and issues as well.
so you're talking myofunctional therapists?
Yeah, I think people that deal with infants on a regular basis.
Okay, they're going to be the ones that can spot it a little easier.
Or yeah, have a bigger picture regarding it as well. Because a lot of the time people go, oh, your baby is sticking their tongue out. And it's really not protrusion or how far they can stick out the tongue. It's really when it comes to breathing and sleep and development of the jaws, we need proper elevation. And even sometimes babies can compensate and they end up cheeks to create the suction. And that's really not allowing the tongue to work either. And it just leads to a snowball of dysfunctional swallowing and orthodontic problems and all that sort of thing as well. Yeah. So working with a lactation consultant that is trained to look at the actual function and the mechanics of the mouth is going to be a really good option.
That makes sense. Okay. And in your book, you talk about, and this kind of ties into this, that we have to focus more on good breathing and sleep as pillars instead of just continuing to treat and manage symptoms with medication and surgery. So in your opinion, if what does this look like to you? How do we, first of all, what does that look like? But then how do we turn the ship? Because I've heard from several guests, they're just not taught this in medical school, or we're not taught this in dental school. How do we fix this?
Yeah, well, I think everybody recognizes that good diet and exercise is really important for good health and health span. But we need to pay attention to healthy breathing. It's the breathing that is the most number one critical function that we need to sustain us. And we need to pay more attention to how does that breathing look like? Is it through the nose? Is it correct, healthy breathing? And how do we get this out? Well, that's why I try to share as much information as I can. And that's why I've written the book. And James Nestor, Breathe, his book, Breath, that was a very, very good book as well to really help people appreciate the importance of healthy breathing. So it's really getting that information out there. And I don't know exactly how to get the information out further. But I do think, things like this book, every day I'm getting emails or messages from different people wishing that they knew this information earlier. And so I think we're only just at the cusp of it's really gathering a lot of momentum that people demanding more knowledge be shared. And I hope that eventuates into something in the future.
Yeah, and can you see, or does it make sense to have these more, instead of separate standing offices or facilities, these things that are a lot more collaborative, where dentists and pediatricians and osteopaths and myofunctional therapists start to work more holistically on patients instead of in their separate little siloed areas?
Yeah, absolutely. Because I think when it comes to mouth breathing, a lot of people think, oh, there must be an obstruction. And the person that comes to mind is an ENT specialist or surgeon who will typically take things out of the nose and the throat to improve breathing. But just as important is looking at the outside framework of the airway, which really comes down to the jaws, because when we don't have good jaw development or we have a narrow palate, we're going to have a limitation of airflow. And this is when it becomes easier to breathe with your mouth open. And then we need to look at the muscle patterns as well, because sometimes when you breathe through your mouth for a long time, it becomes a muscle deficit where your tongue is sitting low and your lips become flaccid and you're just not used to using your nose. And so we need to look at a possibility of speech therapists and myofunctional therapists to help restore those types of deficits as well. And there are all sorts of implications with body posture, and there's a role for many different professionals to get the muscles working well, to help restore nasal breathing and those jaw structures that are the framework for good airway. So yes, it is important that we all recognize these problems. With a lactation consultant, we don't want them to just make sure that babies are feeding without pain or putting on weight gain, they have a really good role in optimizing the muscles, because that is the foundation for the way in which we're going to chew and swallow and grow our jaws. So really helping people understand what is their role. I think there's a lot more multidisciplinary courses and conferences now. So I think that is really helpful to have more and more people on the same page, really understanding that we need to work together to promote this integrative approach.
Yeah, I agree with that. So one part of your focus is also on sleep. And so you talk about sleep studies and how they can help as far as evaluating and coming up with a course of treatment for adults. But when it comes to children, my understanding is there's some limitations that and expectations that maybe we could set for parents because it's very different with children. Yes?
Yes. Yeah. I think, well, there's quite a few limitations with sleep studies in general.
Okay.
And so probably the main things that I'd want parents to recognize, or even adults, when we get a sleep study, it offers a lot of information regarding sleep times, durations, how many pauses in breathing, what are the durations, how much mouth breathing. But typically, all that information gets summarized in a report, and it comes down to AHI, apnea hypopnea index, which is really a measure of obstructive sleep apnea. So that happens a lot with the reports. But really, to get counted as having obstructive sleep apnea, you have to have a minimum of 5 10-second pauses in breathing as an adult per hour of sleep.
Per hour.
So,
okay.
Yes, 5 per hour. And they have to be 10 seconds. They can't be 9. They can't be 8. So it's pretty severe. Like even if you have mild sleep apnea, it's a severe breathing disturbance. And when it comes to children, because of the recognition that children are very vulnerable to oxygen deprivation, they just need to have 1 per hour to get a diagnosis of obstructive sleep apnea. But the problem is that obstructive sleep apnea really is a severe breathing dysfunction. And if we turn around and tell people that this report says you have no obstructive sleep apnea, therefore we cannot really propose any treatment, we're actually missing those really precursor forms or the more subtle breathing disturbances, which also lead to symptoms like snoring and unrefreshed sleep and all the other symptoms with learning concerns, memory fog, because it's very arbitrary cutoff. And so with children do not tend to get obstructive sleep apnea. They tend to have more upper airway respiratory resistance syndrome, upper airway resistance syndrome, which is their sympathetic nervous systems are very intact, and they're more likely to respond. As soon as there's a threat to oxygen supply or a closure, increased resistance to breathing, they're aroused from sleep. And so they do not get those 10-second obstructions. But what that means is their sleep is very, very disturbed. Even if they snore, we know that that is linked to increased risk of inattention, because it is actually really disruptive for their sleep. And so it may be linked to signs like teeth grinding. They're all protective mechanisms to protect against sleep apnea, but really they're linked to unrefreshing sleep. And if we miss that, we are not going to be able to treat well those children that are suffering with those symptoms. So generally speaking, if I have a child that comes in with snoring and they're having daytime issues, I am not really going to refer them for a sleep study, because in my area, it will come down to the AHI. I will address anything. If I think they've got obstructive tonsils or they've got obstruction of their nose, I will send them to an ENT. If they've got a constricted palate, I'll deal with that. If their muscles aren't working, their tongue is tied and not functioning well, I'll look at doing that. So I'll try and address all of those risk factors, because I think what's really important is that we are not just treating obstructive sleep, making sure that children can breathe well through their nose 24/7.
Got it. Got it. All right. So in your book, you give quite a bit of guidance about airway centric dentistry or airway aware dentistry. There are two phrases that we hear a lot of. So how do parents, first of all, identify?
Sorry, what was that?
How do parents identify that they have an airway focused or an airway centric dentist? And then, how do these exams look different than just a regular dental exam?
Yeah, sure. Okay, so how do we identify it? Well, if you're coming in with a child, you want to know if that dentist has any knowledge of snoring or sleep breathing disturbances. Do they refer to an ENT specialist? Do they look at tongue ties? Do they understand that, when do they refer for early interceptive orthodontics? Generally speaking, if you are more airway aware, you'll be more prone to offer that as an option. Younger, you don't necessarily need to wait till 7 to 8. But then again, a lot of people have a problem finding someone that will do the interceptive treatment before that age as well. I think one of the really good questions to teeth grinding. Teeth grinding is a key red flag, one of the strongest red flags in the mouth that a child is not breathing or sleeping well. So even trying to see what do they think about that. If it's something that they say is quite normal, children will grow out of, that is probably not an airway aware dentist, because that is actually what we're taught in dental school. But if they understand that it could be linked to disturbed breathing, that is probably one dentist that will understand it. In terms of what is different, well, my practice is really focused on this type of thing. So I do spend like a full hour for a new patient consult, and we'll go through the full entire history of their sleep, really clicking down into a lot of those type of questions. But for a general dentist, I think you want to hear questions like, does your child snore? What is their behavior like? Maybe some of those questions might mean that dentist is actually interested.
Stay aware.
Yes.
Okay. Excellent.
Yeah.
And so typically at the end of every episode, I like to turn the floor back over to our guests and let you have the final word. And it can be anything. You can talk to parents, you can talk to medical professionals, you could talk to both. If there's anything you want to reiterate, it's completely up to you.
Yeah, that is great. So I think for parents to recognize, a lot of people don't realize that mouth breathing is a problem. People look at their child with their mouth open and think it's cute and full of character. But just to recognize that, yes, it means that your child is not able to sleep to the best that they can, and it can play out with many different issues. And when children have issues like ear infections or bedwetting or speech concerns and all these other things that can be a symptom of poor breathing, we really need to address that poor breathing. And it's not just an ENT surgeon. Sometimes you can get your child's adenoids and tonsils or removed and have grommets placed, but we really need to recognize that those issues may itself be a symptom. And we've still got to manage deeper if we want to address this problem clearly. And so really looking at all the different aspects, whether it be their jaw or their mouth function, to try to optimize those things. And really the book is to help parents recognize those red flags and give them some direction of what are the different paths that they need to look at to ensure that their child develops their airway well. And the best time to find out more about it is even when you're pregnant or during infancy. We may not be able to do everything straight away, but to have that idea, I think will really empower parents to be able to ensure that they're making the best choices for their children's future.
I love it. Well, and again, thank you so much for being on the show and for sharing all of your knowledge. I will put links to everything in our show notes, and just thank you. Appreciate it.
Thanks very much, Rebecca, for having me. I really want my network to be able to follow what you guys are doing as well. We do not need to recreate the wheel in terms of developing resources. You guys have put out a lot of great stuff that we can help share with parents as well. So thank you.
Thank you.